Hello, everyone. I'm Arpita Garud. Me and my co-host, Mr. Arijit Basu, we both are welcoming you in the Business Chat Show. So, guys, before starting the show, I must inform you that a storm is approaching us here. So, in the mid of the show, we may face some problems with the electricity or with the internet connection. So, I would request you please don't, please bear with us. We can get disconnected, and if it happens, we will come back with our guest next week, definitely. But let's hope for the best, and let's start the show. So in this show, we talk about business insights from the leaders of home health care. So our first guest is Mr. Pinaki Chakravarti. So I would like to tell you guys more about Mr. Pinaki. So Mr. Pinaki Chakravarti has been residing in Memphis for over 20 years. He lives in Lackland, Tennessee, with his wife Smita, and have been happily married for 18 years. He is occupational therapist by profession and have worked with the patients of all age groups in different setups for their functional rehabilitation needs. Currently, he co-owns and operates Stillwater Home Health, a locally owned agency that provides nursing and therapy services to post acute patients at the comfort of their homes. He had served as president of the Mid South Bengali Association and also been actively involved in the varied activities in the community. He loves to travel. He loves to watch movies. He listens to music and read non-fiction books. And a lifelong learner. That's a small introduction about him. And I would like to, welcome you, Mr. Pinaki Chakravarti, to our show. And now I would like to ask Arijit. Arijit, please introduce our next guest, Mr. Subrot Mishra.
Uh, Thank you, Arpita. Thank you for the nice introduction. And before I go to Subrat, I would like to welcome Pinaki Chakraborty, our guest tonight, to say a few
Thank you,
words for our viewers.
and thank you,
Uh,
Arpita and Arijit, for organizing such a great event, and thank you NRB News for bringing such great topics and awareness into different discussions during this COVID-19. And thank you for actually approaching us and inviting us to this show and getting to know more about the home care business. Thank you.
thank you, Subrat. Yes, mute. Now I'd like to welcome our next guest, Mr. Subrat Mishra, who is a registered occupational therapist residing in Missouri and is an administrator owner of Sunrise Home Care LLC in Poplar Bluff, Missouri. He graduated from occupational therapy from a National Institute for Orthopedically Handicapped, which is in Kolkata in 1993. He is originally from Orissa and Bengal. He has been living in United States since 1993 and worked in multiple clinics, hospitals, and home health agencies as occupational therapist. He has been having over 25 years of experience working with geriatric rehab. He is happily married for over 25 years and has a son who is studying medicine and a daughter too. I welcome Mr. Subrat Mishra to our show. Thank you, Mr. Subrat, for coming to our program. I welcome you. Say a few words for our viewers.
আমাকে খুব ভাল লাগছে আমি এনআরবি নিউজ আমাকে এই অপরচুনিটি দিচ্ছে কি আপনাদের সামনে আমি অকুপেশনাল থেরাপি আর এই যে আমাদের কোভিড প্রবলেমের ব্যাপারে কথা বলবার জন্য। I also want to thank Arijit and other hosts, and I'm really excited that I'll be able to share my views and my knowledge to this platform. Thank you.
Thank you so much, Mr. Subrot, and thank you, Mr. Pinaki. Now we will proceed to Arpita to start the session.
Thank you so much, Arijit, and thank you so much, Mr. Subrat and Mr. Pinaki. So I would like to ask, the first question, which goes to both of you. I would like to know about your background and your journey from occupational therapist to ownership of a home care agency. So, Mr.
You want to go
Pinaki, would
first?
you like to answer first?
Okay, I can go first. So thank you, Arpita, for the question. So of course, I started my profession as an occupational therapist. As an occupational therapist, my job, or I would say my passion, was to actually bring independence and more functional awareness, and also make them more improvement in their life, actually. So it will be more about the quality of life than the quantity. So of course, it was a great opportunity to work with different people and create a positive impact in their life. But I wanted to actually go and make a bigger impact in the community, and that was only possible when I become uh, or actually take up a bigger position, or actually have something greater that will actually bring more impact on the community. So I decided to actually start working actually in building up a company that would actually provide that services through other individuals. That way I can use my expertise and my education to share like my experiences to more people, where I was seeing only 6 7 patients a day. Now actually, through my education and expertise that I train my staff, I'm able to spread them, or actually send my or distribute my experiences to actually maybe 100 200 patients a day. So that was my journey.
That's very impressive. That's very impressive to having 100 to 200 patients a day. That's remarkable, Pinaki. We'd like to go to Subrat. Mr. Subrat, how did
Okay,
your journey?
my journey is very, very long. It started from Calcutta, India. I graduated back in 1993, and I graduated from a very good school, and we had an excellent education. We we didn't know what kind of setup we are going to go in the beginning. But my first experience with the setup that I worked with the kids in India who had cerebral palsy, and I learned my. I think that was the best experience I had in my life, where I could actually see patients what they need, and I treated them the way we have been taught, and we learned, and that was like my crash course right there. So after that, working there for about 6 months to a year, I was took a job in US, and there was a ad in the paper, and I was the first in my batch, in fact, to come to US. So it was like they were really wanting our profession over here because there was an acute shortage of occupational therapists. So on that basis, we got selected to come with this company, and this company over here was extremely nice to me, and they actually taught me how to provide therapy in this setup over in the United States, because it's completely different than what we have learned in India. Because we have a different setup here. It was extremely different setup there. So actually, I had a crash course with that company too. But anyway, long story short, I have been working with different setups. I have been in clinics, I worked in hospitals, and I have worked in uh, home health agencies in various other states even. So gradually, I worked for myself and learned a lot of business uh, practices, how they do it, and I learned it over the time. And about 10 or 15 years ago, a couple of my colleagues who were therapists, we sat down and we talked about this. And we said, we have worked for a corporate for a long, long time. It's about time for us to start working for ourselves and give it to the community that needs. So specifically local community. The local we are known over here. We have been here for 15 years, and the local people over here know my home health and what kind of services we provide. And I'm very proud what we have been providing so far. And patient satisfaction is very important. They're extremely happy with us, and I'm proud to serve the people over in this country. That's my little.
That's really great.
uh,
That's really great. And talking about India, as you said that in India it is different, and here it is different. So I would like to ask you. I mean, in this question, all even this question goes to both. So we talk about occupational therapy. We talk about physiotherapy. So in India, how it is different, and what is the difference between OT and PT?
Okay, Pinaki, you want me to answer? I'll go ahead first, and Pinaki, you can come in. Okay.
I'll
Yeah,
join you.
yeah,
Yeah,
yeah, yeah,
I'll
Mr.
come in.
Subrat.
Okay. Occupational therapy and physical therapy, it's two parts of a rehab team actually, and those two of these professions are extremely important on patients that we treat. Occupational therapy works more on functional needs of the patients, whereas physical therapy works on more motor or gross function of the patients. That's the basic difference. So what I can tell you as an example is uh, like a patient with a stroke loses the ability to use one side of the body. So what does OT does and what does PT does? I'm just going to give you a brief description. Occupational therapy's role is to make sure the patient goes back to what they were doing before they had the stroke, which is called as a prior level of function. So before the stroke, the patient was pretty independent. One was able to take care of herself independently, was able to dress independently, was able to take care of basic needs of life independently. So after the stroke, they are not able to do that. So what occupational therapy does is teaches them how to do that in an alternative way, or give them the strength back so that they'll be able to do it and go back to what they were doing before. Whereas physical therapy works more on strength, basic strength, balance, walking, and range of motion of the joints. They're uh, much more physical way, and so that is the basic difference. They work more on gross things like walking, standing, balance, whereas occupational therapy works on functional goals, which is so important for them to go back to what they were doing before. So that's a brief difference I just explained to you, and I can talk about this over and over, but
Yeah. So, Mr. Pinaki, I would like to ask you, you if you can give more insights about this.
Like Subrot said, I mean, he precisely mentioned the functional skills, which is actually what an occupational therapist does, is improve the functional skills and bring them to where the prior living functional skills were. So if they have gone to a hospital after a stroke, or maybe a ortho condition, like they have a hip surgery due to osteoarthritis or something, or they had a accident or anything. So the occupational therapist actually work on their functional skills, that can be their daily living skill, homemaking skills, whatever they could do before. It could be as much as like sending them back to work. So doing some pre-vocational tasks to actually send them back to work. And one other thing I would like to add is, a lot of people actually, when they hear the word occupational, they automatically think of job. So let me tell you something. So the word occupational or occupation means engagement in a purposeful task. So anytime the word occupation is involved, it's actually a purposeful activity. So that's what occupational therapy does, is actually improve the functional skills through purposeful activities. That can be in the form of a self-care tasks like dressing. If they're not able to take a bath, they're not able to do something that they were able to do prior to them getting sick or in an injury. So occupational therapists are very important along with the physical therapist. They are all a part of a big multidisciplinary team. So everybody together is working on rehabilitating the patient.
That's
I
that's great. I mean, you have told in very easy and very good words. So it, I'm sure that everyone now knows what is occupational therapy.
Right.
What does it mean? The word occupational, So yeah, Arijit, would you like to ask now?
Yeah. Thank you, Pinaki, and thank you, Subrat. It is, yeah, highly informative because we were always not knowing like what is the difference. Now that you clearly explained, so if I just reiterate, like occupational therapy is more of a functional. It's anything you are getting them back to their normal setting, right?
Correct.
And physical therapy is like more of once they are back, and then you are putting them to have more strength, have a more balance, and make them walk or stand. So that's in a nutshell is the basic difference, right? Yes.
Yeah, that's correct actually. Yeah.
Okay, so thank you. I just wanted to just make it more put it precise. I'd like to go to our next question, which is just a second. It's now that you are how does occupational therapy play a big role in the current crisis?
Okay, it's a very good question. Uh, Actually, occupational therapy plays a big role in the current crisis at this time. As you realize, we have been treating all types of patients, including COVID patients at this time. As you know, when you are have an active COVID with active symptoms and a lot of issues going on, and if you're admitted in the hospital for a prolonged period, uh, we have seen patients coming out with complete weakness, unable to do anything that they were doing for past 30 days back. So if you think about it, I would say occupational therapy and physical therapy both have a big role. uh, there your breathing is compromised. So once your breathing is compromised, that means your weakness and able to do any task is going to be very difficult. So what we do is try to start working on strengthening them, making them sitting, standing, walking, which is mainly done by the physical therapist, but OT plays a big role because we start incorporating what they were doing before for them to be completely independent, specifically going to the bathroom, taking showers, uh, going to dress themselves, groom, shave themselves. So those are the basic things that OT really works at. We not only we help them physically, also we help them psychologically to make them stronger, give them positive reinforcement, so that that gives them a hope for them to come back to what they were doing before. So the whole combination of OT and PT and also psychological counseling also works on this, makes the patients to become strong physically, mentally, and psychologically to go back to their original functional status that they came from. And this has a huge role. You cannot imagine, we have seen patients that have come out of this and are unable to even sit up for 45 minutes doing any task. They're so weak. So gradually we work with them, slowly make sure that they gain back the endurance and the strength to do the activities that we're doing before. So that is a huge thing. Young patients, they have to go back to work. They are not work for 30 days, 45 days, So we had to make sure they were doing what they were doing before so that they're independent and go back to their normal life. So therapy, I know, rehab in general has a big role in this COVID crisis.
That's thank you. And do Pinaki, would you like to?
Definitely.
Yes. Okay. Please.
So basically, actually, like Subrata said, of course, we are improving there. We continue to actually make sure that their physical and psychological aspect of their well-being are taken care of. But again, we forget that overall wellness is affected. If you look at their everybody's routines are changed, and these people are homebound, or actually they have limited access to outside. So they are actually now they don't have family coming to visit them. They don't have outings anymore like they used to do. They don't have friends coming to their house. So they are actually very depressed. So we also have to get actually the mental health involved. So we have to actually be a counselor. We have to prepare a care plan to involve actually not only the functional physical aspect but also a mental well-being, because I can actually have like put down a list actually when I was preparing, because there were some patients that talked to us about what do I do? My daily routine is affected. So we actually help them as an occupational therapist or as a physical therapist or as a nurse or somebody. We help them, okay, why don't you create a program? Involve yourself in activities like do some passive. You can watch TV, but don't watch TV or don't watch news all the time. That will impact you negatively. That will even make you more stressful, because if you hear like there are 20 people, 30 people affected by COVID, it's not good for your health. So we tell them watch TV, but also limited. So we actually plan that, okay, make sure they get enough activities, because if they don't get it themselves involved in activities, they are not going to get a good appetite. And healthy eating is important. A sleep cycle important, like healthy sleep. They need to get their full hours of sleep for them to be energized. So basically you have to also incorporate that, because as a home care provider, overall wellness or overall health and well-being of the patient are very important. And secondly, COVID, actually you have to, like, you look at a patient as a whole. So it's actually like we are actually very playing a very pivotal role actually, because sometimes we are the only persons that they see for this duration. The nurse or
Yes,
the
yes.
therapist or the social worker or whoever actually they see. So that's the reason we have to create a plan or care plan actually, which actually helps them make sure that they stay healthy and maintain a proper balanced lifestyle.
Absolutely, absolutely. So now that you talked about mental health, and nowadays, mentally and physically, there are many
Correct.
aspects you are handling right now. So I would like to ask you, how do we access home care need for
Okay.
patients?
You want to go first on that too?
No problem.
Okay.
Okay, I think I'm
Yeah,
in
just
first. uh, how do we get referrals for? How do we identify the patient needs home health? Is a good question. Uh, First thing, a patient needs home health is when they are prolonged. This is a very common thing. It can come from a hospital. It can come from a clinic referral. It can be identified by a nursing home discharge. So basically, patients who have been prolonged in the hospital with different conditions, uh, and they either come with physical problems like orthopedic conditions, neurological problems, or strokes, or like fractures. The social worker at the time of discharge, when they go home, they receive therapy at the hospital too, but hospital will keep those patients for so long, and then they have to discharge them home in their home setup. So the social workers in the hospital who works as a discharge planners, they call the home health agencies and tell them that we have a patient going to home and would need your services, and would you like to provide that? That's how we get the referral from the hospitals. In the nursing homes, when they are there for a long time, they are usually there more than the hospital. They are there for about 30 days, 60 days, sometimes 100 days. And when they get out, some of the patients choose to stay in the nursing home, but a lot of the patients would like to go back home. And once they want to go back home, they would like to continue gaining strength and be confident when they go home that they can function in the home setup. That's when the discharge planners or the social workers from the nursing home, they call us and they wanted to refer that patient for home health services. Also from doctors' offices, they see patients all the time, and they can directly refer us with different problems that they are facing in home or in their work. And if you can provide that at the home, if the patient agrees that they want to do this at home therapy, they'll refer to us directly from the clinics. Now, one thing with home health, one of the big condition in the home health is they have to be homebound. There's a big confusion about homebound, which I can talk about for a long time. When home health services was first started in this country, the homebound was a big issue. At the time, the homebound definition was the patient has to stay home and they cannot get out for anything practically other than somebody helping them out on getting things. But the things have changed over on the past couple of years. Now they can go for their doctor's visit. They can go for actually shopping for their groceries. They can go to the church. They can go for uh, a small private family get together. It can be in home. So they have been very flexible with the homebound situation now. That's the reason home health has become so important that we can provide it now, which is much easier than before. Previously, there were so many stipulations, and so to make sure they're in the homebound status, that was the only way you could certify them in home health services before. But now they're very flexible, and with COVID, with the COVID or the current crisis, they have given us much more flexibility than before. So.
I would just like to add that he mentioned pretty much everything. The process of the referral, of course, just to make it easy, like you can break it up into like any referrals coming from institutes like hospitals, nursing homes, assisted living, like a structural building, and community will be the doctor's offices. So those are primary referral sources. And coming back to, like, you just have to have relationship with those people actually. And also, it's especially in the area that we are, you have something called the star rating, and the better your star rating in the agency, the more referrals you get, because you are actually putting yourself in the forefront if you're a better star facility. And second thing is, of course, your reputation. The more people know about you and they have been in under your care and they have gotten positive reviews, you get referrals because of that, because we have customers or clients or patients that has been actually happy with you before. So reputation goes a long way. Another thing will be, of course, it's always word of mouth. There are a lot of actually patient and even actually clinicians and their family members can be referral sources actually. So they tell their friends and the friends tell their friends. So basically it's pretty much you get patients from different sources. And anybody, as far as the looking for the types of patients, any patients or any person that has a significant decline, like if they had a decline actually due to any conditions, it might be a neurological condition, orthopedic condition, any condition that has a significant decline in their function or medical needs, they actually qualify for like therapy or nursing through a home care agency. And also actually, of course, because of the COVID, the homebound status has been relieved a little bit. They have actually made it a little bit, because if they're home because of the COVID, they automatically qualify as the home care services. And Medicare and other insurances also waived a lot of things to make it easier for the patient or their families to take care of them. And more people are able to get services because of that.
Okay, that's great. So, there are many people, and we are getting many comments in the comments section. We are getting questions. So, I would like to ask that there is Mr. Satya Gopal Day. So, one question from his side. I'm gonna ask both of you that we learned about OT and PT. So he is asking, is there a very thin line between OT and PT? And also whether so he was asking, there a very thin line, connection between OT and PT? Yeah, the same question.
Are
It's me. Yeah.
two, sorry,
Yeah, go ahead, go
this
ahead.
both are, yeah, this both are two different professions and two different disciplines. Yes, there's a thin line connection because we work together. We have to work as one rehab team on this. Now, like I said in the beginning, that PT works more on gross things like gaining back strength of a particular section of the body. Or, like they can walk, so they walk them, learn them how to walk. If their balance is bad, they teach them how to gain their balance. Now, OT, on the other hand, work parallelly with them. We also work on balance. We don't work on walking that much. We do work on balance. Now, balance is such an important thing, like when you're sitting, like a sitting balance, or standing up is a standing balance. But we do a lot of functional tasks while standing up and sitting down in our daily lives. You can go to the kitchen and you have to stand up and you do kitchen tasks, right? So we have to make sure they have their balance while doing the kitchen task. So that's a functional aspect. Now, what PT will not do is the patient will go to the kitchen, but he has to pick up utensils. He has to pick up different, he has to manipulate different heights to reach for different things, and even do some cooking. PT will not work on those. OT will do. So while the patient is cooking and cleaning utensils or moving utensils, those are various movements that OT will work with the patient, whereas PT is going to mainly work on just standing up and working on balance. But we do work together. Sometimes we share our goals with them. They help us out and we help them out. So we work as a team.
So Arijit, would you like to go for a next question from viewers?
Yes. There is Mr. Ranjan De. He is asking, is work ergonomic more of a domain occupational therapy? So, yes, I'm putting that to, I don't know who can take it.
Well,
So, whoever wants to.
Pinaki, you want to answer this or you want me to? It doesn't matter. But OT works, ergonomics is a complete different setup, and it has affected a lot of businesses. Okay. Yeah, as you know, the computer software industry and all these different jobs that we have is a sitting job, and they work in computers day and night, working and looking at the computers, the keyboards, and now that creates a lot of problems which people don't understand. It creates neck problems, it creates back problems. So ergonomics has really evolved, and this is a recent, not very long, maybe 15 years. I think this has really progressed to where it's becoming a huge industry. Like a lot of big companies want OTs to go there and teach them proper body mechanics, how to sit properly, how to make proper adjustments to the table, to the computer, to the heights, how to stand. A lot of people work in the factories, they stand like for a long time. Standing for a long time, we have to do some changes so that they have less pressure in their feet or their body. So, and how they need to take breaks, not work in one full thing and take rest breaks. So this is becoming a huge field. Yes, OT has a big role in ergonomics, but unfortunately, the insurances here has not picked up that as a possible payment. Now some do. Some, when there's big companies like Coca-Cola or something, they do pay for ergonomics. It's a huge. They actually have an ergonomic team where they recruit OTs and physical therapists even in the ergonomics team, and they pay it because that saves them a lot. A lot of this workplace injuries happens, and they have to pay for workers' comp, which is a work injury, and that costs a lot of money for all these big corporations. So they have been hiring ergonomists, which you have to take a course and get certified. There's a way to do it, and that are usually done by occupational therapists or physical therapists, and they have been working on that, and that is becoming a huge field actually, and I think it has a big opportunity for us. So I hope that answers.
Yeah, all I want to add is again.
Would you like to like add few?
Yeah. Just let me add a little bit about
Okay.
it. Yeah. So pretty much ergonomics and occupational therapy, because again, it's coming to functional, and ergonomics is actually a study of work efficiency. It comes to it can be actually properly, like right now we are in front of the computer, the way we're sitting, for us to be, if we slouch and sit for too long, it will cause back problems. If you're too close to the TV or the monitor, it might affect our eyesight. Or so basically ergonomics is actually where you assess those needs and actually make a workplace productive and also safe, and actually prevent any injuries. So basically it's actually, and of course, like it's a special subject and it's a special speciality that you have to actually get into. But again, like it's more about education, and you have to have a separate program, because insurance will not pay for prevention. The way insurance, they pay for get sick, then we'll pay for it. So basically it's like I said, a lot of places, even actually FedEx have programs like that. They will actually spend on actually a part to actually protect and prevent those work injuries. Because if you're not picking up, especially in the hub, if you're not picking up things right, the work economics and those things are very important. You have to stand properly, hold things close to you. So there's a lot of different things that goes with it. But again, that was a great question actually, Mr. Dev, that you brought into. So it is definitely a part of occupational therapy, I would say.
Yes, thank you. Thanks to both of you, and thanks to our viewer who put the question. It's a very interesting question. I'd like to take one more question, two more questions from the audience before we go to our next questions. Mr. Day also is asking, I remember during my practice, we used to send patients to occupational therapy for FCE and determination of disability. So I guess, yeah.
Okay, let me answer that, because actually functional capacity evaluation, again, that's a different, I mean, again, it's OTs can do that, but again, that's a specialty. Like work hardening, it's like ergonomics is also a specialty. You can choose to do it, but again, like it's not a regular part of OT practice. It has to be done as a separate specialty. If you want to specialize on work hardening, you can do that, but it's just normally in a regular practice, people don't do that. I mean, like PTs, OTs both have done work hardening and done the functional capacity evaluation, but it's actually because of the reimbursements and all that is just, I mean, I've not, especially in our cities, we don't have a lot of those.
I Subrat, would you like to?
Yes.
Okay.
Yes, it is more functional capacity evaluation. That is more like in the outpatient setup and work hardening program, like Pinaki just told. In home health, we do not have any functional capacity evaluations. So,
Okay. So
but
we are
yes, that
getting.
is a part of OT.
Yeah.
Okay, so we are getting to know more about OT and PT differences, and
Yeah,
thank you
and
so much.
as our viewers are also asking us the questions, so it makes us, very more curious about, these two
Yeah,
subjects.
uh,
So,
That's a nice question.
then something, yeah, it has come in my mind. I would like to ask you this question. how to how do you differentiate between skilled and unskilled home care agencies, because now that you are sharing about a speciality speciality of some programs and for you OT, so yeah, so how do we differentiate between these two, like unskilled and skilled home care agencies?
Subrot, you want to go first again, or
Sure, I will explain
okay,
from my end when you can.
okay, then I'll go next.
Now, yeah. Now, over in US, it varies from state to state, but I can tell you difference between skilled and unskilled. Uh, like the home health agency I am associated with, we are a skilled home health agency. What we do is we provide therapy, nursing services, social workers, and aid services only for training. And all this, the skilled means when you certify a patient on skilled services, what what the insurances want to look or how it has been set up is called a skilled, is they want to see a progress. Okay. Suppose I started a patient who was not able to sit up, but now he's sitting up, doing activities. That's a progress. Patient was not able to walk or stand, and now they're able to walk and stand, and we measure it in different things. Now that's a skill service because the patient is progressing. So actually we are comparing from when we started and what they're doing now. And if it is done by professionals, by physical therapist, occupational therapist, speech therapist also is there. They deal with swallowing and speech. So those things are measured progress, okay? And that is when the skilled thing comes in. Whereas unskilled is more like maintenance, okay? Like if a patient needs daily help of cleaning, cooking, and all that, and if somebody's providing that in home or needs a companion service, staying at home, just sitting in home, babysitting the patient, those are all unskilled services. Now, skilled services are reimbursed by different insurances and federal programs. Unskilled services are reimbursed by a state program mainly, and it varies from state to state, and different states have got different regulations. So basic difference between skilled and unskilled is skilled always involves progress. If we cannot show progress on patient, this patient is no more skilled. It's going to switch to unskilled. That means they have reached their optimum level of function and they're going to maintain on that. For maintaining that level, they have to be, they need seek help from unskilled workers. So that's how a basic, in a layman's term, I just told you, that's what basic skilled and unskilled portion. Now in Missouri, we have skilled home health agencies. Also, we have home care services, which are called in-home services. In-home services, they provide aids daily. There may be a nurse that comes and sets up medications for them. That is also a part of that, and it's usually reimbursed by Medicaid. The state program reimburses them, or some patients pay it privately. So, but with us being on the home health side, we are skilled, and it is usually a federal program and different insurance programs that pays that. So there's a big, that's the major difference.
Um, okay, let me
Yes.
bring a different perspective to my idea of what skilled and unskilled is. Basically, think of skilled is actually it's a licensed person that has special qualifications and skills to provide to the patient. Unskilled is somebody who has they have the knowledge of the requirements, but they are actually doing something that's more about maintenance. For example, like a nurse has actually, they are licensed and they are actually trained to take care of a patient, give the proper medications, and do wound care and other things that's required. Similar with the therapist. So in perspective, let me put this way: a skilled is if any person is not able to do it themselves and require a special person to do it, it's skilled. If it requires, if anybody actually can be it can do it with some training in the house, it's an unskilled. So basically, just to put it together, let's to explain it, is just it requires a special training. It's just any average person can do it. It's more about short term and just more about more detailed, and this is actually long term and more of maintenance. So especially this will be more like skilled nursing care that will go twice a week for maybe 4 weeks till the patient has improved status. And here it will be like somebody who needs actually daily self care for maybe 6 months, and they may need companion care. They might need somebody to clean the, do some regular self-care cleaning, giving them bath, taking them to the doctor's office and stuff like that. So that's in short a difference between a skilled and unskilled service.
Uh, I unmute yourself, Arpita. But before Arpita goes into the next question, I'd like to take up one more question from the audience, because we are getting so many questions today, and it's nice.
Yeah.
It's just becoming more interactive. It's great
It's
feeling, and
great.
I just
Yeah.
other than the questions, there are so many other things like. You both are a great guest. Like talk, you had someone said it's a very insightful talk, and Subrat, Pinaki both provided very useful information. Someone mentioned, please write a practicing manual of OT. It would be a hot cake. And, Pradeep
Thank you,
Sarkar,
thank you.
Pradeep Sakar mentioned very nice to see you, Subrat, as well. And there's one more question. As a psychological counselor, he has been practicing office politics. Okay. So the question is, if a person is a victim of office gossip, office politics, whether OT would be a help to the person? I'd like to ask Pinaki this question.
Of course not, actually. That's more of a administrative policy thing, because if somebody is gossiping, there has to be a policy in place about behavior that's more of a disruptive behavior. I mean, OTs will not be able to do anything. That's more of a administration job, like to, because that's more discipline or disciplinary actions if they are creating a problem or they are like having office politics. So definitely not. I mean, that's nothing to do with OT. That's more about that's more administration.
Okay, that's great to know. Yeah, I was also thinking in that line, but you are an expert in this field. So, Arpita, would you like to go to the next question?
Yes. Yes.
We are still
Yes. Yes.
we
I've
are still
answered it. Yes.
getting
Yes.
many questions, but we will go with our questions first before we take up the audiences.
Yeah. So my next question is, I would like to know if you have gone through any situation where you managed risk effectively, explaining the situation, the opportunity you had to manage successfully, the action you took, and its results.
I'd like to ask Pinaki this one. So Pinaki can start with this one.
Risk. I mean, running a business is a risk in itself. No, I'm just kidding.
Indeed, indeed.
Yeah, no,
Indeed.
I'm just saying that risk management is a part of any business. I mean, risk management is a part of any business plan. So, of course, in home care, this, because it's a highly regulated industry, there is a lot of things we have to take into consideration. But let me just kind of like just to discuss about the current situation, like COVID-19. Okay, because of the pandemic, we are in a PHE, so that itself is a big risk to health and well-being of the patients, the employees, and pretty much the whole community. So that's a challenge and also an opportunity to learn and grow and become more aware of the health situation that we are currently in. So, of course, we have to create and implement new procedures, policies, do a lot of teaching, training, not only to the employees, but also to the patients and their families about COVID 19, the prevention, protection, and also promote wellness and be aware of the signs and symptoms and the risk factors that goes with it. So we just make sure that everybody is trained on the screening processes that has been uh, you know set by the CDC or the Tennessee Department of Health or whichever the state we are in. So we follow that guidelines and create programs. And last few months have been constantly training and making sure that everybody is trained on something we call as infection control, which everybody knows by now since we are in a pandemic. But it was a common thing among healthcare, even to start with, because infection control is pretty much actually is promoting or safeguarding the health of a patient and not getting anybody infected. So mainly that was the primary risk factors that we have been taking into actions. Of course, you cannot totally eliminate anybody having COVID or not, because you cannot control individuals, but as long as we have the plans and the screening processes and actually the reporting, because we have a process where they actually report to us and we report to the authorities. So it has been working fine, actually, as long as you follow the guidelines set by the CDC and have a program with the policy and procedure in place, and all the staff and the whole your entire group has been trained on that. Risk can be mitigated. Like they say, actually, you cannot be ever be audit proof, but you can be audit secure. You cannot totally eliminate risk in your life, but you have to identify them so you can actually be prepared. So that's the main thing here.
Uh, Subrat, you have anything to add? Now that we thought like this program we would can wrap it up by 1 hour,
Uh,
but now that it is getting so interesting, and I'm sure with so many questions coming, and you both are really speaking so well, and I think we have to continue for some more time. So you want to elaborate on this?
yes, I think Pinaki covered most of the risk currently what we are facing. Uh, Now, the biggest risk right now is, of course, COVID exposure. Uh, we see multiple patients in their homes and different uh, in different areas. It's hard to track who they have seen, what who they are meeting with. So anybody can bring in that virus to them, and it can come to us, and then we can give it to the second. So there's a huge risk out there, no doubt. But what we are trying to do is we are strictly, if we know that the patient has been exposed positive, to COVID, if he has any signs and symptoms, the first thing we do is we tell them that they have to do a test, and we request the physician, or we request the community health over here and refer that patient down there for testing. On the same thing, we have to take care of our employees too. So we make our employees test too. I know it is pretty, it's been a challenge. It's been a challenge that we have been doing. And we are, the front warriors, I know, but at the same time, we have to prevent the spread too. So what we have been doing is if we see something and we think there's a positive exposure, we make sure the patient get tested. Make sure the therapist or the nurses that went into that home, they have been tested, and now they have been tested like twice, once every week for 2 weeks. So it's a 14 days. So far, we know there's a 14-day rule. But in the meantime, if I made a policy over here, if somebody's tested, somebody has been exposed, we don't allow them to see patients. We don't allow them to come to the office. They're like quarantined. Sometimes the patient may not have a choice, that they may not be able to see that clinician. So we've tried to find alternative clinicians to see those patients. So it's been an evolving procedure that we've been working for weeks, and I know it's going to go on. And I'm here. I'm very happy to tell that my state over here in Missouri has been giving us PP, all the PPE equipments like mask, gowns, goggles, shields, which we initially did not have, and it was very difficult to get. But now the state is sending us by like boxes.
Wow.
So that's a huge thing, that the government, the local government is doing for all the agencies like us, and that really brings us, uh, a positive hope that we'll be able to serve all these people. So yes, there's a lot of risk involved, but we'll fight for it.
Now,
Yeah,
before
that's
Arpita,
true. That's
now we are like doing having almost close to an hour. Now we will take up with the questions, and I would prefer any of you would pick up whichever you feel best. So we would be happy to have you know both from you.
yeah, because
Yeah,
both of them are, they're being very
very
informative
informative,
and
very informative. It's so many things we are knowing from you. I will not spare more time. Arpita, over to you.
yes, yes. So, my question goes to actually both of you. How do you ensure patients' satisfaction? So, Mr. Subrat, you want to go first
Sure.
about satisfaction?
Yes, there are so many checks and balances that we do that if the patient is satisfied or even the patient's caregiver or the family members, they are very concerned. What we do in each and every visit, we actually develop a very close rapport with the patient, and we ask on each visit that if they're satisfied with our treatments and if they are seeing a progress, if they think they're progressing, if they think we are doing what needs to be done. In other words, very open communication that is just by talking. But also, despite, instead of that too, uh, I have made a policy for any clinicians that goes in home, they need to ask this question, and I make my staff call from here and ask, like, if that therapist came on time, if he provided everything that was supposed to. So we check on that too, and we ask directly to the patients or the family member. Now, there's another round of checking that happens, which is a third party, which we have no control over. And that's basically a rule from Medicare here, that a third party actually sends a survey to the patients directly. And there's a bunch of questions over there. What good of a service we did? Did we actually provide the service on time? Everything was provided, what there was provided. And this has been directly reported to a star rating system that actually determines how all the home health agencies are rated at. So yes, there's a lot of checks and balances, and we make sure that the patients are satisfied, they get what they need. And as an administrator, I'm very always concerned about that. I always make sure that my agency provides the best service that we can provide within our means.
Um, to answer the question, I will just put it into simple. I believe in the three C's. The main C is actually for any satisfaction or anything. First thing is compassion. The patient needs to feel that they are being taken care of. They need to feel that caring nature, because that's over and over. Actually, we have been working as a clinician before, and if the patient doesn't feel that they are being cared for, no matter how
And
much we
I,
do for
I
them,
guess
they don't
this
care.
is for every doctor. I mean, everywhere. Even we as a patient go to any doctor. We feel, we need that feeling.
Exactly. So satisfaction starts from a compassion. You got to feel, if the doctor talks to you and attends to you and answers your questions, you feel actually, wow, you feel good about it. You will go back to the doctor. If the doctor comes and just tells you, okay, what is your problem? You don't feel that. And the second C is communication. Again, that's a very crucial thing. A lot of problems that we have in any industry or any, actually, especially in home care, is that actually if there is some delay in care, there is no communication, or there is actually the patient was not informed, or the patient's family was not informed. So we always mention that keep the lines of communication open. And the third C will be is called the care coordination. So basically, when a person, you accept a patient as a home health patient, the patient is, you are a case manager or care manager for the patient. So if you see a problem and you are not able to solve it, if it's not in your scope of practice, make sure you resolve that by talking to anybody in your team. It might be the nursing, it might be the patient's family, it can be the doctor's office, it can be like a social worker or somebody actually. So be a resource for the patient and help him get that answers, and sometimes that goes a long way. So basically, any satisfaction, if you follow these three C's, I believe they will come back to you over and over again.
Arpita, I think yours is, you have to unmute. Yes, rightly said. Three C's are the key: the compassion, the communication, and care coordination. And we are getting so much of positive vibes from you both. Like we are delighted. And Arpita, please continue with your next question.
Arijit, would you like to ask any question from viewers?
I will, but before that, let's go with the questions we have with us.
Okay, yeah. Right. Exactly. So, I would like to ask you guys, can you bring nurses or other healthcare professionals from some other states to meet patient demand?
Just to answer that, actually, that's kind of a very state subject actually, and the differences, it's different state to
I
state.
think I think this
So
one, yeah, I think this one we should because
I
it's state
I
specific.
it's very
I
state
think
specific, and
Yeah,
actually it's like a, it's a
yeah.
very regulated,
uh,
like I said, it's a regulated, so we don't want to actually talk about it, because actually we don't want to say something that might not be right in a different state.
I
Yes,
understand. Yes,
exactly. So we will skip.
okay, okay. I can tell this. All the nursing staff, all the nurses are multi-state licensed mostly because they have that license for multi-state. Now,
okay.
if I want this state, I have to comply with my state regulations. Now, if
Mhm.
Pinaki state, he has to comply with his state regulations. So it's a very it depends on we have to do all the checks and balances and see if they'll be able to help or not. So
Right. So now, just go on to the next question. Like, what has been the most, like, the significant impact on technology on your business before and since COVID-19?
Want to go first?
okay, yeah, I'll go. Okay, when we first started in this home health, when I started working as a therapist in home health long time ago, we did not have we did not have any technology really. It was all
Mhm.
pen and paper. We had basically different forms that we filled out and communication forms we filled out, and we talked on the phones with the case managers. Those days are gone. Now we have all this high technology EMRs that
Mhm.
has been done in last 15 years, I would say. It's like an open line of communication pretty much. The EMRs are so great. It's all built in into every communication you can think of. You can do intramail, you can send doctor's orders to to their offices through the emails. You can even do stuff from your own phones now. So things are changing in a big way. And lately, with the COVID situation, as we know, telehealth is coming as a huge thing where we can be doing some televisits, and Medicare and other insurances are going to allow us to provide some telehealth visits, and they'll actually reimburse for it too. But if you talk about therapy, how can we do televisit and tell them to? But there's ways we can do. We can teach them home exercise programs. We can teach them how to do things properly. We can teach them safety. What are the things they need to look at? If they're in oxygen, we can tell them how to measure their oxygen regularly. If they're measuring their blood sugars regularly, those things can be done on telehealth. So, so it's a huge change. I mean, I can talk about hours how this all is going to change our total industry, which I'm really excited and very proud to be a part of it. So,
Yes, I'm sure. This is you. You both are expert in this field. You can talk for hours. And on this, Pinaki, would you like to like?
Um,
This is such a
like you said, actually, we both have been a therapist for so long. We started from actually the days when we did not even have a GPS. We used to actually drive around, like we used to call it handy map. So we used to call the patients and ask them, okay, they used to tell us, hey, come by the third lane. You'll see a white picket fence, a red car sitting outside my yard, and that's my house. So those were the days when actually you have to be more creative and you have to actually make sure that, because all you had was a pager. We did not even have cell phones. So basically, and cell phones was like, it came literally like in the later part of the 90s, but we started when, at least I started home health when actually everything was on paper, no technology. So of course, now everything is like electronic. You can reach people right away. I mean, you can.
It's easy now.
Yeah, I mean, and easy actually, but I mean, one technology only problem I have is people are losing their creativity. Now, if you now the clinicians we are hiring, they do not know the zip codes. I used to have my zip codes memorized. If you tell me this is the patient in
I
381, I will know exactly. I just need to look at the name of the street. I had
That's
the
very
whole
true. Very
Memphis map
true.
actually on in my head actually based on this map. But now actually they will have to look at it. You have to actually like Google it to them, Google Maps. But of course everything has changed. But it went from actually handy map to MapQuest. At one time we were starting to give people MapQuest with their like the paperwork. So that was the age, and then of course everything is electronically. And the main impact which we had now is of course telehealth, because not only that actually keeps the patient satisfied, but also, I mean, again, coming back to the compassion, they know somebody is there. They are not left out there, especially patients who are in quarantine and the family are not able to visit them. They feel peace of mind because somebody is watching on them, because they have that. It might be once a week, twice a week, depends on who is doing it and how often they are doing it, because it's still not a reimbursed service, but it still actually is done as a to improve patient engagement and patient satisfaction, and also actually prevent any decline in the function. So that's the main area. And again, like we are doing now, most of the conferences went from a board meeting to online meetings. So now we have Zoom meetings every Thursdays. Everybody comes on to their tablets. You just send them a request. They will, everybody, hello, hello. Okay, this is what we are discussing for this week. Everybody, they sign it because it's a requirement actually by the state that they have to have trainings and they have to be educated. And it's pretty much, I'm sure it's in Missouri too, every they have clinical requirements. They have to be trained because it's called this conditions of participation. The state have like so many different, especially like they're like, I'll just throw your name, infection control is one, bag checks, and those things are there. So you have to be trained, and they have to be educated on that. So instead of them coming, we just bring the program to them. And of course we have, now we use a program called Reliance. So everything is in a training format, and that have boomed in the last few years too. If you open online, there's a lot of like healthcare training programs that do only trainings to employees. So those are actually very helpful, so they can just do it from their houses or they can do it anywhere and still be compliant with the state regulations. And technology, actually, of course, like a cell phones, they are the best things. Pretty much everything can be done. They said, oh, I need this, I cannot get to a fax machine. Don't bother, take a snap, email. So everything has become so easy. So actually, even though we are actually distant, we are not disengaged.
Uh, now that you explained it so well, that you have struggled in when the technology was not there, but it was, so that's why you have come to this far. And I'm sure that's why you have gained so much of expertise, knowledge, and inputs to share. So I'm sure that I don't know how about the generation, the next generation, because they will be more technologically savvy or orient. Like so, you have the more in-depth knowledge about it. I'm
I
really
think I think
yes.
I think they're going to they. it's not too far, I think, when robots will do help for
Yeah,
them.
that's true.
Uh,
But again,
Siri,
knowing
Siri and Alexa's already taken over them. Alexa,
right.
fix my tablet, fix my tablet.
That's true. That's very true. Arpita, let's
you
go to
know,
the
you
next.
know, I,
Yeah.
I just need to add, technology is so important. You
It's
cannot
important,
imagine
of
the
course.
patients uh, that rely on blood sugar measurement and different things, which has really evolved so big. You know how many diabetes patients we deal with every single day. A lot of people even don't know how to measure it because they don't have even have the strength to put the needle and measure. So now we have this patch that has come out, and they can actually measure it by your phone, smartphone, as many times you want, and and that can send the information directly to us
True.
and make sure they're doing it.
Remote monitoring.
So
So instead of somebody going out there, information is transferred to your without
EMR,
going
straight.
out there.
How
Yeah.
accurate is that information?
I mean, of course, I mean,
Yeah,
it cannot be accurate as actually manual stuff because, when electronic things are involved, there is actually a small discrepancy. But again, that can be eliminated, because of that, because of course, if somebody doesn't know how to do it and they have the best, like the actual sphygmomanometer that are used, and you use actually a wrist, there will gonna be a lot of like there's almost a 10, like mgs of difference. But I mean, it's better
but
than not taking it.
better than better than not taking it or not knowing what's
Or
going
not
on.
knowing actually. And especially if somebody has high blood pressure, if they're not
That's
sure, they can have a stroke, they can even die, so at least they're getting a base measure of what's happening. So at least technology, like I said, at least it's a resource and it can actually be more beneficial. Again, it can be misused, but that's how anything and everything can be done.
right.
You both are a ready reckoner kind of a thing. So the one of the audience rightly mentioned that if you have write a practicing manual, it'll be a hot cake. I'm sure.
Sure, I read that.
so, so Arpita, we are running out of time. Quickly,
Yeah,
ask a
so
few
I
more
would I
questions
would
to
like
them.
to ask one question, one last question that now that we are talking about COVID, what are some of the challenges or rather changes you had to overcome for in office or clinical office in the field post COVID-19?
A lot
Yep.
of changes.
Yeah.
Uh, the first change we had to do when first it started back in March and April, I remember, is first thing we had to put a stop sign in front of my office. Let nobody can enter without signing a log. So that was basically CDC. We followed all CDC protocols. So how my office was open to most of the people that can come in here, all my employees. That has all changed. We measure their temperature, we document everything. They have to fill out a questionnaire that if they went somewhere over the weekend, have gone travel different state. So yes, the culture is completely changed in the office now. Also, we have implemented wearing mask at the office too, because we are home health. We go to different places. Go to different homes. So the chances of us getting exposed is way higher than other agencies. Just like other skilled unit or something. They're in a fixed place. So it's a complete change. I mean, we tell them to wash their hands regularly. Wear gloves and mask and even when they go to see patients, it has changed. Like, we used to just go to a home, we're ready to treat them. Just go in and do that. No, it takes about 5 minutes to gown up and, just go and provide the service. So, yes, a lot of cultural change, a lot of questionnaires. We check each other, make sure everybody's healthy and well. And that is a part of we all have to fight with this COVID. And we have been all doing that. I think Pinaki may add some more.
Yeah, so Mr. Pinaki.
Yeah. Basically, like, of course, the first thing, um, regular preparation, office preparation, clinical staff getting prepared. But the first thing when the PHE was declared, actually, we had to go through something called the emergency preparedness, because that's stuff that we have to do actually as a part of the agency, is like do a preparedness. I mean, it's a regular plan, but we had to add a new pandemic plan, like a pandemic, what are the special, and made changes to our infection control guidelines, of course. And then everybody was called in the office, and this was before actually everything got started, when they declared it as a pandemic. And like I said, actually, the offices were closed to any visitors. Only office staff that worked in the office will be there. The clinical staff, they have to call in before, if they have to pick up any supplies or they had to pick up anything, they had to come by. And of course, they would make sure that they wear mask and everything. All the temperature was checked, and we have a screening tool for everybody that has to come in. They have to answer all those questions, about, it started with actually, have they left the country, have they left it. Now it has totally changed, so that has gone through changes. The screening process have gone through changes. First it was, have you moved to a different place, then it actually got changed to, have you met somebody that has come to your house that's COVID. So again, like, it's a constant change. I mean, like I said, I mean, change will be, like, it's like, and plus, you have new laws coming in, staffing, and one thing we don't even want to bring up, and it has always been a challenge, and I'm sure actually he will agree, staffing is a major challenge. That's the biggest challenge in home care, because I mean, first of all, it's like, I mean, you have people come and go, especially for the nursing assistants. Like, they have a lot of demand in the job, so they will go, actually, even if they get a 20 cent or 50 cent rise, they will leave, and they will leave you with a heartbeat. So there's nothing like that. So again, that has become a challenge. So we had to do a lot of recognition and reward programs that has to be added to keep them. We went actually, I mean, we are not a big company, but we also actually included hazard pay as a part of, actually, like, that was like something to keep them motivated. If they saw COVID patient, even if they didn't see COVID patient, it was still included actually with their pay. We implemented that COVID hazard pay. Of course, we uh, actually honored a lot of different nurses as essential worker. He actually honored them. We gave them certificates. Everybody is still getting gift cards if they actually go above and beyond in their job. If we get a positive review from them, because we do Google reviews and everything, if we get positive reviews about a nurse or a therapist, we try to, I mean, it doesn't have to be much. It can be $25, $50 gift card, but we actually give them, and that has actually kept the moral. And they're really, actually, they have helped them actually to stay and be more engaged. And they have actually been very good. I mean, like, some of the people now that have joined us after, or right before, actually, they are still actually carrying on. There are few that have changed because they had to move out or they had family problems, and especially now since school. And that's the last changes I'm going to tell you, which is again challenging. Is again we have, like, because of the school system, that's especially in the Shelby County, Memphis area, is going virtual. Everything is virtual learning. We had to do a lot of actually working from home. We have to actually rotate our staff, like, office staff, like, given them opportunity to be at home a few days a week, maybe 1 or 2 days, it depends, and then rotate them. Maybe one person got like twice a week, like Monday or Friday, the other person got Tuesday and Thursday. But so at least we actually keep them happy too, so they will. And we have, I mean, again, that's telecommuting has a new role now. I had to work on that a lot because we were not prepared before this. Home care business was not actually designed for telecommuting, especially it's still not for people who see the patients, but especially the office staff. We had to bring in policies, actually have call-ins, have time cards, and different login and clocking in procedures. I mean, you're talking about changes. It's been changing. I'm like, I am learning. I am changing too. And then things are changing.
Yeah, I'm sure because the what pandemic has taught us, like the change has to be there and change for the betterment. If I can sum it up like that, because now that you rightly said, that motivating, the employees, the motivating the whoever is around. Telecommuting is one of the important factor which is really growing, and it'll stay. It's not that it'll go off. It is going to stay in the new
Oh, yeah,
normal period. Yeah, and all this, I'm sure, is bringing a very positive change to the to all of us and to the entire mankind as well. And I'm sure,
Yeah, at
uh,
least we are, keeping ourselves safe.
yes,
We are keeping ourselves hygienic, which we tend to ignore earlier, or probably,
yes, very
And
much,
now,
very much.
we go everywhere, we check our hands, we wash our hands, we sanitize everything. So this should
Yes,
be a part of our life anyway, and we tend to, ignore it.
yeah. And one
yes,
thing I would like
that
to add actually, because I mean, and I'm very big on health and wellness actually, like because I would
yes. I
like to.
was about to ask the question to you. Yeah, you can continue with
Yeah,
it.
and
So
August is actually a wellness month. So what we do is actually every month there is something going on actually. So we try
Okay.
to actually bring and challenge our employees to actually participate. I mean, of course, we don't do it as a part of the bigger corporate like they do it, like FedExes or all like bring it like a big thing. But we try to do it in our own small ways. Like we try to, and even last week actually we talked about that healthcare workers, even though we are resilient, we take care of other people, but we forget that our self-care is also important. We are important.
True, true.
If
true, true,
if we
very
actually
true.
don't take care of ourselves, like especially like some of the healthcare worker nurses and all that, they work so hard, but they forget that they need to take some time out. They need to actually engage in self-care activities like actually pampering themselves, take a sauna day. I mean, of course at home it's like difficult to go out nowadays, but at least like do things to actually help and improve their quality of life, like also spend time for yourself, not just be out there taking care of family, friends, and being the caregiver they are. So that's what I tell them, that if you are sick, if you are no good, then there's nothing you can do for others. If you are sick yourself, you cannot
Of
be,
course.
you
Very rightly
cannot
said. Very
actually-
rightly said.
I mean,
Yes.
it's basic, thing. So I tell that to everybody, even the community actually, just take care of yourself, and then you become a better community member and you are able to help the rest of the world.
Yes, absolutely right.
And
Yeah, super.
I, I, I come from a very small community, not like Pinaki. You guys in a big city. Over here, the challenges I faced with the staff was with the COVID. Mainly is if we have a patient that we think has COVID or come from a facility, I had to really talk to the staff and convince. They're all concerned. And we always treat them as a part of the family. I give them positive hopes and positive experience. Try to like what Pinaki does, and we have tried to give them. Uh, Actually, the staff are glad that they have a job. A lot of the other, if you look at other fields, people have been home and they're like not been paid, and they don't have a job. They may be getting half paid. Whereas with our agencies, with home health, it's been open. It's never been shut down. So they do understand. I go through all the psychological process and I talk to them about this and I tell them how lucky you are. You are not stopping your work. You're still actually doing some stuff which is very positive and actually doing for the community. So I try to work with them on that and give them very positive. Of course, money is another
That's really
aspect,
important. Yeah, that's
and money is another aspect, and we need to reward them for that, and we do that. But I'm telling you, the most important thing is giving them hopes and be positive in this job, because it is not a very fun. It can be fun, but it can be
exactly.
depressing too. So
Yeah.
Yeah, 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 very true. And now that we are almost at the, well, we thought about 1 hour, it is 1 hour, 30 minutes, close to that. And it can go up to 1 hour, 30 minutes more. But we
no,
have
I
to
think
draw a line. Yeah, we have to draw
I
a line.
think
But before, yeah, tell me, sir, Subrat.
no, I think that's enough.
Yeah, that's enough. But we have several more questions from the audience. I think this 1 hour or 1 hour 30 minutes
guess
is not enough.
Arijit, we need to call them again in our show.
Again, exactly. That's what I was
Sure,
thinking,
sure.
because we have to come up with them again with many more questions from for them. And
Sure.
thank you so much. And we only hope that you keep well, do well, and whatever you are doing in your field, it's remarkable. We had a lot of inputs from you, and I'm sure with all the comments pouring in and with the likes we are getting in our website in this live broadcast, we are extremely overwhelmed. And thank you for being a part of this show. Thanks to you,
Thank you so
Arpita.
much. Thank
Namaskar.
you,
Wrap
Mr.
up.
Subrot. Thank you, Mr. Pinaki. Thanks, Arijit.
Thank you.
Would you like to say any message, Arpita?
I would like to say to our viewers that thanks, and thanks for your views, thanks for your comments, and people who missed our show, they can come again and watch anytime. And please do like the page nrbnews24.com, and do comment on the comment section. So it will help us to bring more innovative things to you. And
Yes.
thank you so much, Mr. Pinaki and Mr. Subrat, to come on our
Thank
show.
you.
It was really,
Thank
really
you.
nice talking to you. And the session was really very informative and interesting.
Thank you. Thank you.
Yes. Thank you so much. Thank you.
Thank you.
Thank you.
Namaskar.
Thank you.
Namaskar. Okay, bye.